Hello, everyone. Season's greetings and welcome to today's webinar from the Agency for Healthcare Research and Quality on how patient narratives can support your patient experience strategy. My name is Dale Schaller, and I'll be moderating our session today presented by the agency's CAHPS user network. Next slide. Just a few housekeeping details before we get started. If you have any trouble with audio, you can do two things. You can contact Zoom by using your phone. You click on the phone call icon, find the dial-in number you need and the meeting ID, or you can have Zoom call you by selecting call me and then enter your phone number and you get a call back from Zoom. If you have trouble with connection, you can always sort of log out and log back in. Most importantly, today we'll be using the Q&A icon for all of your questions and for troubleshooting any trouble that you might have with the webinar. We will not be using the raise hand and chat feature, which are usually available on Zoom. We encourage you to ask as many questions as you would like, and please submit your name and organization if you feel comfortable so we have some idea of where you're coming from. And lastly, today's webinar has an event site at the URL shown here on the screen, https://events, events.westat.com/CAHPS for CAHPS /webcast, WEBCAST. There you can find the slides for today's webinar, plus the agenda and bio information on our terrific lineup of speakers. Next slide. So our agenda for today will begin with a brief overview from the agency about the CAHPS program, and also a look at how patient narratives, which mean accounts by patients about their healthcare experiences in their own words, can be used to complement information that is obtained through the closed-ended CAHPS survey questions and other patient experience measures. We'll then hear from three CAHPS team members, very outstanding members of the CAHPS team for many years, who are going to share their insights on their research into narratives and describe how patient narratives can be used to identify and address improvement opportunities. We're then going to have a panel discussion with each of our three panelist presenters before we get at the end of the webinar to your questions and answers and wrap up for the day. So again, please submit your questions throughout the webinar. We'll get to as many as we can before we conclude the webinar at the top of the hour. Next slide, please. So our lineup of speakers will begin with John Bakdash, who is a social science analyst and a key leader of the CAHPS program and the SOPS program, which stands for Surveys on Patient Safety Program at the Agency for Healthcare Research and Quality. And then our panel begins by Rachel Grob kicking off. Rachel is the director of the Qualitative and Health Experiences Research Lab at the UW, University of Wisconsin-Madison. Rachel will be followed by Yuna Lee, who is assistant professor of health policy and management at the Columbia Mailman School of Public Health. Rachel, if you can turn on your camera. And then we'll end up with Denise Quigley, who is a senior health policy researcher at RAND. And then again, I'm Dale Schaller. I've been a member of the CAHPS team for a very long time, serving as your moderator today. With that, John, I'm really pleased to turn it over to you to get us rolling.
Thank you so much, Dale. Welcome, everyone. Thank you for joining us for the last CAHPS webcast of the year. Today, I'm going to give you a brief overview of the Agency for Healthcare Research and Quality, AHRQ, and give you some background information about the CAHPS program. The CAHPS program stands for Consumer Assessment of Healthcare Providers and Systems. Next slide, please. I want to tell you a little bit more about the Agency for Healthcare Research and Quality and how the CAHPS program fits within this agency. AHRQ is a research-based agency. It's part of the U.S. Department of Health and Human Services. We are the lead federal agency charged with improving the safety and quality of the healthcare system in the U.S. As a research agency, we do not have the authority to require the use of our tools or surveys or submit survey results to us. So if there are requirements or options to use CAHPS programs the requirements do not necessarily come from AHRQ. We do encourage the use of our tools and products, but we do not require them. So AHRQ has a lot of investment in patient experience and hosting the databases for selected CAHPS surveys. Next slide, please. So AHRQ's CAHPS program is focused on advancing the science of measuring and improving patient experience. And this includes using validated surveys for high-stake purposes, supplemental questions, including narrative items, which we'll be covering in detail here, quality improvement resources, databases for selected CAHPS surveys, and research to advance the science of patient experience measurement. The CAHPS program has been around for almost 30 years. And we've required a lot of expertise in measuring and improving patient experience. The tools are free, as are the materials, technical support, and other resources. Next slide, please. What is patient experience? Patient experience is what actually happens to a patient during in a healthcare setting or with a health plan, or how often something happens. It's this range of interactions that patients have with the healthcare system. And this slide illustrates some of the common elements of patient experience that are measured in CAHPS surveys. I really want to emphasize that patient experience is not the same as patient satisfaction. Patient satisfaction is how patients feel about their healthcare, whether or not their expectations are met during healthcare, not what happened to them or how often something happened. Patient experience measures are objective and actionable for quality improvement. Patient satisfaction measures are subjective and have a different purpose. And the CAHPS surveys really focus on aspects of care for which the patient is the best source of information. For example, only a patient can tell whether a doctor communicated in such a way that a patient could understand. And the CAHPS questions are tested to make sure they are understood and interpreted consistently by a wide range of consumers. Next slide, please. Now, CAHPS surveys are a way of measuring information from patients and collecting it. So it's a quantitative method, and there are other survey instruments too. Some examples of qualitative methods include patient narratives. And in this webcast today, we're going to show you how CAHPS surveys can be combined with narrative information to provide more additional detail that you cannot get from just a closed-ended survey alone. And other qualitative methods include focus groups, interviews, journey mapping, and there's also patient partnerships which provide information through advisory groups and on improvement teams. All of these methods add a perspective to patient experience and different aspects of it. Next slide, please. I wanted to give you some examples of what the CAHPS narrative items look like. And these are open-ended questions here that are structured. So what do you look for in a provider? And these are the 5 open-ended questions that are used in the narrative item set for the clinician and group CAHPS survey, the CG CAHPS survey. And the reason to ask these is they bring a greater depth and richness than you could get from just the CAHPS survey alone. So these are intended to complement the closed-ended questions. They provide a rich source of value-added information that's helpful to both patients and consumers, as well as to clinicians and staff. And the narrative items are tested with the same degree of scientific rigor as the closed-ended CAHPS questions. Next slide, please. What do you get by adding narrative items? So you get a combination of the closed-ended CAHPS items, but you combine that with the open-ended items for information that is not measured by a CAHPS survey. So that's the green box there. So really, we're trying to provide additional information that you may not get otherwise. It's not possible to ask every survey question to assess every possible experience the patient has, which is why we provide narrative items for some of the CAHPS surveys. Next slide, please. And we have information on the CAHPS website about narrative item sets. We currently have narrative items for the CG CAHPS, Clinician and Groups CAHPS survey, and also the Child CAHPS survey, which is for inpatient pediatric care. Thank you so much. And now I'm going to hand it off to Dr. Rachel Grob, who's going to talk about research and patient narratives.
Good afternoon, everybody. A pleasure to be with you. Next slide. So I'm going to kick us off in our investigation of how patient narratives can support patient experience improvement by sharing a narrative about narratives. This story is one told by aggregating what 20 middle managers in an ambulatory care network recounted when asked to reflect in hour-long interviews we conducted with them on how they used narrative data generated by patients in their clinic. Like all good stories, this one includes some insight about the motivations of its characters, as well as a plot detailing what they actually did. So let's start with the motivations. Why do middle managers value narratives? We heard at least 5 reasons. One is that it enables better patient experience assessment by helping explain why survey scores are high or low and reflecting patients' actual experiences most accurately. It deepens understanding of and relationships with patients, highlighting specific experiences of subpopulations within a clinic, identifying how patients may feel stigmatized by specific practices or structures, and helping to build patients' trust and responsiveness of the clinic to their needs. It deepens operational knowledge, providing a view of experiences in the clinic over time, and also providing insight about what's happening that's not directly observable by middle managers themselves. We're going to talk about areas of improvement and potential solutions in a minute. So the last motivator I'm going to focus on here is the facilitation of agenda planning and execution so that managers have validating evidence to provide when advocating with upper management for resources and a way to inform long-term strategy and direction for the clinic. Okay, so now for the plot. Middle managers described using narratives in various ways in their roles as leaders. They employed them to focus staff attention on improvement, using positive ones to reinforce behaviors landing well with patients and negative ones to identify behaviors that need to change. Managers said narratives promoted deeper learning in their clinics. They used positive ones to allow staff to learn from one another, by example, and negative ones to invite group learning and group think about how to do better. They used narratives to motivate change, drawing on positive ones to keep momentum for improvement going and negative ones to prompt a search for solutions. Both negative and positive narratives helped managers reinforce a sense of purpose with their staff, highlighting the importance of the clinic's work to its patients and encouraging humility and dedication when things did not go as planned. Finally, narratives help managers recognize staff strengths, for example, using positive ones to celebrate what's going well and do recognition work, and negative ones to guide decisions about where staff maybe should be reassigned within the clinic so their specific strengths align better with patients' needs. Across the board, these narratives also catalyze specific improvement projects by drawing attention to issues that patients feel need to be addressed, suggesting solutions, which you'll hear more about from Yuna shortly, motivating staff, as we've mentioned, and demonstrating success, since narratives collected after improvement projects were implemented in these clinics often reflected how patients' experiences were in fact improved. Next slide, please. So this figure shows how the parts of this narrative about narratives connect. First, there's a learning phase where middle managers absorb and process new knowledge from qualitative feedback, and we went over those pieces a minute ago. Over time, they're able to use this knowledge to cultivate a service-oriented workplace culture and to catalyze concrete and specific improvement projects, which we document in the paper from which this figure is drawn. All these mechanisms I just described when talking about the plot of the story are in play during the change phase over there near the right, which in turn sets the stage for improvement in measurable outcomes, such as organizational processes and metrics, patient experience scores, and workforce experience. So in a nutshell, there's my narrative about narratives, and I hand it over to the next speaker.
Thank you so much, Rachel. So good afternoon, everyone, and what a pleasure to follow on from my colleague. I'm delighted to share our work on leveraging patients' creative ideas for learning and innovation. Next slide, please. So the first aim of our overarching study was to develop and evaluate an effective elicitation method to elicit patients' creative ideas. And our team recognized that this aim has both a conceptual component in that inviting patients to share their creative ideas for improvement is likely to be an unfamiliar position for patients to be in, given the historic emphasis on engaging with patients as passive recipients of care. And there was also this methodological challenge of how to invite this sense of comfort and trust and motivation within the context of a survey question. So we embarked on a lengthy process that had multiple stages. First of all, we did an environmental scan of all existing surveys that invite suggestions for improvement from all industries. We then did a comprehensive literature review that engaged with a variety of literatures that were focused on inviting suggestions for improvement. And we sought to identify sort of underlying design principles that may inform the development of our prototype improvement idea related questions. So you can see on the right of this slide here some of these principles. The first was derived from the customer service literature, and this principle was to draw on past exemplars of excellent experiences with the idea that anchoring in past experiences can be really evocative. The second design principle that we identified was to be explicit about inducing creativity. And this was informed by the field of design thinking, which really emphasized a future-focused ability to invite creativity explicitly. The third design principle was from the customer grievance literature, and this was emphasizing the importance of the impact and importance of feedback for the system and the organization. So this literature really underscored that patient feedback, if it is seen as valuable, important, and potentially usable by the organization, can be really powerful. And then our final design principle was thinking about the potential of combining these design principles in one survey question. So potentially having the first sentence reflecting one of these design principles and having a second sentence really emphasizing the impact on the system. And so we generated a series of prototype questions based on these design principles. And a really important part of this process was that we worked with patients and their families, patient advocates, and patient experience professionals to really refine and shortlist these questions. First of all, we worked with a patient focus group, and then we did a series of cognitive tests to really to refine the questions themselves and to generate a final list of 4 questions that you can see on the right of this slide. So using these 4 questions, we then engaged a representative sample of 600 patients who were actively managing a chronic disease. And these patients received a version of a survey that involved the close-ended CAHPS survey, the 5-item narrative item set, and one of the 4 versions of the improvement idea question that you can see listed on the right. And through analyses of these respondents, particularly sort of differing analyses of the differences in responses to each of the arms of the improvement idea question, there was a clear result that we found that the 4th alternative for the survey question, that is having a first sentence that was explicit in the invitation to share creative ideas, and the second sentence that emphasized the impact of the feedback on the system or the organization. That particular survey question generated the most actionable responses in that there was a lot of content there for an organization to respond to from an improvement perspective. And these responses were also rated as most creative. And the way that we did that was that we had an expert panel of primary care and patient experts rate ideas and responses for level of novelty and level of usefulness. So that was sort of the insight from the first aim of this study. Next slide, please. I'm not going to share the second aim of the study. I think that I'll elaborate on that further in the panel discussion, but I do want to share the third aim of the study, which is where we took our validated question to the real world, and we administered CAHPS, NIS, and the new improvement question surveys to a sample of 3,000 patients in a large healthcare system in New York City. And we're really heartened and encouraged to see that of those 3,000 surveys that we received, we identified 2,980 patient ideas embedded in those patient narrative comments. And we were really interested in understanding the ways in which these ideas may prompt organizational learning and innovation from the organizations that are reading and digesting and analyzing this data. And we found very similar, sort of speaking directly to Rachel's presentation, from a content thematic perspective, that these ideas contained information on existing challenges. So these ideas often shone a light on existing challenges that were hiding in plain sight and provided a strategy to solve them. They were also clearly focused on specifying new interventions, so often sort of identifying a strategy or intervention that could be developed or implemented by the organization. Some of the ideas were really effective in highlighting and amplifying exceptional practices that were worthy of being spread and sustained, or exceptional people who were worthy of recognition and role modeling. And then finally, a subset of creative ideas were focused on forecasting hopes for the future. So these were ideas that were a little bit more blue sky, long-term, radical in nature, that could be used for long-term innovation, development, and planning. And so overall, I think that the findings of our study are really aligned with this concept of a learning health system, where we think that these insights suggest that creative ideas embedded in patient narratives can be a potentially useful form of data for organizations that are interested in improvement and innovation. Thanks so much, and I'll pass it on to my colleague, Denise.
Hi, good afternoon. My name is Denise Quigley, and today I'm going to share the insights that we gained working with a medium-sized children's hospital with an academic medical center, which uses child HCAHPS survey data to improve their pediatric inpatient experiences. Next slide. So the child HCAHPS survey includes an open-ended question that elicits comments in the parent or guardian's own words as narrative text. The question is here listed on your slide. The hospital has administered the child HCAHPS survey for several years, the one that we worked with, and they were willing to also, besides conducting the one open-ended question, they were also willing for a year long to field what was developed as a 6-item narrative item set that is now available for the child HCAHPS survey. We then took it upon ourselves to compare the content of those narrative comments and also the actionability of the comments. And then we compared what was received in the narrative text responses from the single item open-ended question and compared that to that of the 6-item NIS. We also conducted analyses to understand the added value of the open-ended comment data over and above the information that's collected through the closed-ended survey questions on the item. Next slide. So most comments we found refer to content asked about the child HCAHPS survey that's contained in the measures. 50% of the comments refer to the child HCAHPS measures content from the single item. And then we see that 82% of the narrative text from the NIS are from the content on the child HCAHPS survey itself. But as John mentioned earlier, that also means if you flip that 50% of the information for the single item narrative comments were outside of what is contained in the closed item survey measures. So this indicates that the single item compared to the 6-item NIS set provides more insight into topics that are not asked about on the survey itself, if that's something that your organization is most interested in terms of deciding which to field. Secondly, we also found that most comments from either the single item or from the NIS that are in the child HCAHPS survey context are about 3 main particular measures: treated with courtesy and respect, explaining care at discharge, and being kept informed. So that's where there's a lot of rich additional information on those specific measures that are contained in the open-ended comments. We also found that more negative comments were provided in response to the NIS than the single item. We also, when looking at the narrative text, we judge the text and see if it contains specific enough and detailed enough information to make changes or improvements based on that information. That's what we call actionable information for the organization. And comments from the NIS contained more actionable content than what was solicited from the single item question. But the one item from the NIS, because it's a 6-item set that was tested, the question that reads, "What do you wish had gone differently?" yielded the most actionable information and comment. Lastly, as I said, we predicted the overall hospital rating and also the willingness to recommend the hospital rating with child HCAHPS composite scores. We also included indicators of whether the comment data was actionable, whether the comment data was negative, et cetera, in terms of its types of what content it contained. And we also controlled for child and respondent characteristics. And when we ran those models, we found that negative comments and also the actionability of the comments were both significantly associated with child HCAHPS global rating measures, both of them. Each of them individually, so a negative comment or the actionability of a comment, they each explained an additional 8% of variance in respondents' overall hospital ratings, and also an additional 5% in their willingness to recommend the hospital. And this is a large percentage given that the full set of composite measures on child HCAHPS together combined explain about 43% of the variance. Overall, this indicates that the child HCAHPS comment data really does provide significant additional information about what's important to parents and guardians during their inpatient pediatric care experience beyond what is actually captured in the closed-ended composite scores. Practically, this also implies that during improvement efforts, there should be an activity that includes a review of narrative comments, particularly those that are deemed either negative or actionable, alongside reviewing the performance of the closed-ended responses. Because by doing that, you can help identify ways to improve inpatient care experiences. Thank you.
Thank you, Denise and Yuna and Rachel and John for kicking us off. What a wonderful set of very brief but content-filled overviews of a lot of research that's been underway for the past decade or so on patient narratives through the CAHPS program. We're going to take the next segment now, invite Rachel and Yuna and Denise back on camera. We'd like to basically try to address many of the questions that came in through the registration. There were a lot, and then sort of fashion kind of a panel discussion here among the three of us. Denise, are you able to turn your camera back on? Yes, great. Okay, thanks again. To start, Rachel, I'm going to field this first question to you regarding how patient narratives for improvement actually differ from the use of the closed-ended survey questions and CAHPS questionnaires.
Thanks, Dale. Many differences, I think, both in terms of sort of collecting and working with the data. Denise referred to, different options for how you collect qualitative data, but you need a system for understanding what those data are that is a little different than the sort of more biometric or statistical analyses that happen with the score. So a little bit of a different skill set. And I also think in terms of use, to refer to something that both Yuna and Denise mentioned, the actionability content that the qualitative data has creates a really different sort of improvement pathway. The scores, you can tell if they're sort of going up or down, or if they're giving you good news or bad news, but it doesn't really answer the question of why, except for in a more speculative way, whereas the comments will tell you why things are going well or why they're not going well from that sort of objective measurement, as Jonathan called it, from the validated tool that's implemented.
Yeah. Great. Thanks, Rachel. Denise, did you have any comments on that particular question? Or Yuna?
Sure, I'd love to just add to Rachel's comment. I think Rachel's comment is so sort of insightful when we think about the closed-ended questions. and the open-ended questions really giving us a sense of why. There was one finding that I didn't present, the AIM-2 of our study, that actually put together the closed-ended survey responses with the creative ideas. And we found actually that patients that were sort of overall dissatisfied with the care that they experienced as reflected in the closed-ended scores, they were also the patients that were most likely to generate actionable ideas, so ideas that had a lot of content for actionability in terms of response from the organization. So I think just to add another sort of nugget to that picture, I think that in some ways the narrative also can provide the how of how to address the what and the why that's really being surfaced through the sort of patchwork and synergistic picture that we're getting through the survey scores as well as the narratives.
Very good.
And I think only to add to that is that obviously it takes a lot of sifting through all the comments, because we're talking about, reading them, thinking about what they really contain. I mean, it is true. That's why we have looked at, and all of us do, which comments actually contain all the specific wheres and whats and hows and like give rich detail. It's very often that they'll see one piece, but they won't see, you won't hear all of the pieces that you want to know, able to make a change. So that's why we consider them or deem them actionable, because they contain all the specific pieces of an information that you would want. But as we've said, there's high percentages that do that. It just requires the sifting, the reading, and the selecting of which ones can actually be used for improvement.
We had a number of questions come through, again, on the registration regarding evidence that there is about the use of patient narratives in contributing to improvement or reflecting evidence that improvement has actually happened. And Denise, I know that was a question, now that you're off camera, that was a question I think you were going to take on at the beginning.
I'll try to see if it works with my camera on, just to be able to respond. Let's see, so the evidence I can provide is not from the study that I just presented, but it is from a study where we worked with this clinician and group CAHPS survey with a federally qualified health center. And what it was is we had already ran an evaluation where we documented over time that there had been improvements in the composite scores for the provider communication composite and also the overall provider rating. And it was from an intervention. The intervention was at the provider level, and it was a peer-to-peer shadow coaching. And they were aiming to improve care experiences and also provider communication. That's been published in the Journal of Healthcare Management in 2023. And what we did is we thought, well, we know there's been improvement in the CAHPS scores and the measures. So let's see if we can see that reflected in the narrative comments. Because that way you would be able to say, well, are the comments able to also reflect improvements that we see in the survey measures? So what we did is we looked at a set of the comments just prior to the coaching for each provider and just after the coaching. So there was about 1,000 comments that we looked at before the coaching and 884 after the coaching. And what we did is we did the same. We described the valence, which is the tone, the positive, negative, the neutral. We actually did the same where we looked at the actionability of these roughly 2,000 comments. And what we were able to find is an overarching statement was that the patient comments really did reflect those improved CG-CAHPS scores. And they did that in several ways that were sort of interesting to see in the data. One was that there was a proportion of positive comments increased about the providers. So when they improved their, and had the improvement from the coaching, they got more positive comments from their patients in response to the one item question that was on the survey. We also saw that comments about doctors specifically were much more positive. We also saw that comments about spending time in the exam room decreased, apparently reflecting the decreased proportion of negative comments that had been there about their time in the exam room with the providers. We also saw that comments regarding 3 of 4 of the aspects of the types of aspects of provider communication asked on the CG-CAHPS survey were more positive. We saw that in listening carefully, showing respect, and spending enough time. And we also saw that comments described a much more overall positive evaluation of the practice itself. That increased. And then comments were generally less actionable after the coaching. And we think that's because there had been a lot of actionable comments specific to the provider needing to change the way they interacted with the patient, and we saw those go away. So these results suggest that the patient comments from the CAHPS survey really can be used as input for quality improvement when you're doing an evaluation. If you see the shift of the proportions of types of comments in the area that you're actually seeing the intervention going through. And so that tracking valence and tracking the content of the comments is also very important when you're thinking about before and after an intervention to improve care. And it's a practical method to sort of see what kind of information you're bringing in. So that's the evidence I can say from CAHPS. Thank you.
So I would say that we do have, I mean, just in sum, a fair amount of evidence in the literature now that is available. And actually, we will give you a sort of a set of citations at the end of the webinar in the slide deck that actually has a number of the pieces of the literature that you can consult to look at the evidence. Rachel, I just wanted to quickly ask you, I think one of the projects that I know the Yale team worked on for a number of years was with New York Presbyterian. And any comments you might just add quickly about the evidence that was collected to actually show patient narratives can make a difference in a number of ways?
Yeah, as you said, the literature will tell a more complete story, but really building on some of the things that Denise also mentioned, seeing how the sharing back of narratives can affect and improve scores was really the focus of the Yale team's study. And we could see that most clearly with respect to sort of office staff performance, and a little less clearly so far in our results with respect to the clinician behavior. So it's a really interesting place for us to keep refining, because our results were a little bit different than yours, Denise, in that respect. But absolutely, as you said, Dale, a clear, demonstrable improvement in scores, which we hope is motivating for more people to take on the important work of collecting these narratives and using them in your own settings, because it really can make a difference.
Right. Yuna, I want to ask you a question about, and some of these concepts have been touched on already, but the idea, or maybe a few examples of how patient narrative information can actually be integrated with other kind of feedback from patients. Do you have any kind of thoughts on that?
Sure. Well, I think within the context of our team, we were thinking a lot about the learning health system and this idea that there is data that's being generated from patients on an ongoing daily basis through healthcare delivery, and patient narrative information and patients' creative ideas really have just this potential to provide this insight and input for improvement and innovation from the organizational perspective. So I think that, one important piece to consider is that this information is both complementary and synergistic with other forms of performance and quality information that's regularly collected at the organizational level, whether it'll be quality, safety, and so on. I think it really sort of, this information in an integrated, if it's integrated well, it can provide a very comprehensive picture of not only the patient experience, but also how the organization is supporting the patient experience. And I think with regards to how these forms of data complement other forms of patient feedback, I think it's also true that patient narratives really represent a more representative sample of patient voices and detail. And so the sort of more traditional, conventional data that we collect from patients tends to be a little bit more ad hoc and less representative. So I think that this also provides really a potential for understanding a more comprehensive picture of the patient and what their needs and preferences are, and how the organization can respond to it.
So on the issue of representativeness, and this was actually, I'm just going to kind of pivot to another question that came in registration, and actually pitch this, I think, back to you, Rachel. Rush Medical Center posed a question about any insights that can be gleaned about disparities in care revealed through patient narratives. Any thoughts on that, or kind of evidence of that?
Yeah, I mean, I think we see this with the narrative item sets that we have already published. The work that I was just summarizing in my narrative about narratives included narratives from that item set that Jonathan introduced at the beginning, which didn't ask specifically about sort of equity or disparity related issues. Nonetheless, we had a good number of people talk about things like how the physical space of a clinic, for example, made them feel very stigmatized or made them feel like they were, you know, one population or another, or how they wanted their sort of privacy and illness identity to be treated within the clinical setting, and whether that was working well or not. I will also add that in some separate work outside of the CAHPS enterprise, it's also funded though by AHRQ. I've been working with PI Dr. Mark Schlesinger, who's probably on this webinar somewhere, and another team to develop specifically some narrative item sets that are designed to help people reflect on how their identity as they define it, and also how they think they're being perceived, how their healthcare providers are perceiving them, is playing into their care situation. And we have some scholarship coming out specifically in that area that I think is going to be really exciting. I know that some of the folks who are using the narrative item sets are already sort of interested in this additional question. So stay tuned on that as well.
Great. We have a ton of questions that are coming in, and we are limited in our time. I want to try to get through as many as possible. But before we move to those, let me just ask all three of you kind of to comment from the sort of the big picture on overall lessons learned in your research on patient narratives, and particularly sort of challenges or ways in which doing the work that you've described kind of runs into issues that really need to be overcome. So Denise, I'm going to turn to you first.
Thank you. Well, the challenges can be many, depending on the type of organization, because to actually incorporate all of these narrative comments, as we all know, even as researchers, it does take the time and the energy to focus on reading them all. Typically, what I've found, organizations will read them relatively frequently. So the question then becomes, like, how often do you read them? How do you send them out? How do you use reporting of them? And so I've seen this done in multiple different ways. One example is in a hospital setting, they will send out, they'll review them first, depending on the organization's decisions amongst staff. A lot of times when they're positive, they will use them as reward and recognition statements. They will share those in regular meetings. It's also true, though, with a first pass with valence, a lot of times also the vendors will give you at least the positive and negative as the valence. So sometimes that's an easy sorting mechanism that's given to you by your vendor, not necessarily content oriented, but you can use that as a general pass to be able to divide them into larger buckets. But then someone does read through them and make decisions on what can be shared. That's internal to the organization. I've seen this done on a monthly basis, and I've also seen it done more on a quarterly basis. In some ways that depends on the volume coming in, because it is a staffing and time issue. We're currently working with an organization where they're wanting to learn to train their team to actually code them more for being actionable. And they're trying to use that within their QI team. It's not yet published, but we're in the process of doing it. We decided to help them along, that we would compare researchers coding to clinicians coding to see how well each do. Very fascinating. I've always wanted to do that to see how we differ. It's not yet published, but one of the things we did find is that clinicians tend to pick up much more on patient safety issues than researchers do. I think that's their broader context. Someone mentioned, I saw in the chat, about patient safety and collecting narratives. And so they saw many more of the descriptive comments being things that needed to be dealt with on a patient safety level than we as clinicians did. But we had very good agreement on what was actionable in general, and also what, various big content buckets, even if it was in the survey, not in the survey. And so we're moving forward with that to help train them a little bit more deeply so that they can fold it into their conversations that they do for QI. Now, I understand also that means you're taking the narratives and a smaller set of people that are responding, and there must be some thought about who it is that does respond versus those that don't. So it is true that it still needs to be done alongside what's collected with the closed-ended survey scores and the performance that's going up and down. The way that I've seen that work well is that you still identify your areas of QI with your measures. And then after that, you dive into the content area from the narratives to find out additional information, as Rachel and even Yuna said, that's where you get the whys and the hows. So you don't necessarily pick always the topic from the narratives. You still use your survey data and your performance to sort of decide on those larger topics, but you use the narratives to fill in the richness of understanding what's going on with the patients.
Great. Yuna, Rachel, I'm going to ask you to do your sort of sign off at the end of the webinar. I want to get to some of these questions first, and I'm going to try to find a way to cluster some of them because we have quite a few. There are several here that are relating to the ways in which, once the data or the comments are collected or elicited, how can that actually be processed? A lot of the research that you guys have described has used qualitative kind of teams of trained reviewers to sort of sift through and make sense with coding frameworks. What are the trade-offs, and what other ways would you be able to comment on using sort of more mechanical or machine-based learning, AI or natural language processing? Any comments on how to begin to address a large volume of comments and the scale, or is there some mix of the two that you think would be advisable? Let that go to anyone who wants to take it on. No one?
This is
Go ahead.
perhaps it's kind of a tough one for people who do a lot of qualitative work, but a really, really important one. I would just say from work that the RAND CAHPS team led, that I think there's a lot of promise in the AI machine learning domain, and there's a lot of creativity coming from the one project I was part of that's completed and published as a RAND report so far. A lot of promise in thinking about how the humans thinking about care improvement and the AI processes can continue to intersect, and sort of where the humans need to get in there. For example, to see sort of the harbinger of a new set of issues emerging in the data that the machine learning hasn't yet caught up with. So I think protocol development around how to make sure that humans are encountering the data sort of the right amount to continue retraining AI usefully is the direction that I see the field going in the years ahead.
Dale, I would just add to that. I think that the promise and the caution of how we can integrate these new tools, which are here and potentially helpful and transformative, are very much reflecting the conversations about how these tools can be integrated into healthcare more generally, and what are the thoughtful, skillful ways in which we can harness these tools to really make use and make sense of just a ginormous volume of data. So the extent to which they can really support meaningful analysis and integration and interpretation, that seems to be a mission that it's an issue that we're all grappling with generally in healthcare and more broadly in the community and society. So I think it's an important one to continue to reflect on and work on together.
There's a question regarding how narratives that highlight issues related to social determinants of health can be used maybe as a staff training tool to increase their awareness of the broader context affecting patient care. Have either of you or any of you sort of found a way in which those issues percolate up through the narratives that can actually be fed back for staff training and education?
I might just mention the final finding from my study, and I think it has some relevance here. So one of the findings from our study was that patients that have minority racial or ethnic backgrounds were more likely to generate highly creative ideas. So these were ideas that were rated as being novel in that they don't appear in the organization already, and they were also rated as being useful. And I think the insight that our team took from that finding was that we're really scratching the surface of understanding the diverse perspectives on improvement and what is needed to address needs and preferences for our patient population, particularly addressing important questions around underrepresentation, social determinants of health, equity, and so on. So I think that there are real opportunities in using that data to learn, and I think it's a great potential application to think about using the data for staff education and for informing initiatives and training. I think that that's a great link there.
Very good.
I would add, I think for the health equity perspective, it's true also that we're still pushing the envelope for people to even use their composite scores and look at them not as just overall whole, but also look at them across racial, ethnic, language groups as even a base minimum in terms of seeing not just their overall performance, but looking at which particular areas there is lower performance when you look just under the surface of not just overall scores, but look at different patient populations that are important to your organization. And in the same way, I think that when you do that, it shows you which ones are more important to the different patients and individuals that you have coming through the door. And then in the same way, you can look at the comments that come from those surveys, and you'll be able to see that there are differences in terms of the types of topics that are raised, or and even if they're not talking about a specific like chronic issue or disease, but you can see that they cluster many times in the issues that they raise. And so I think it's being able to have that health equity lens across the closed-ended and the open-ended questions in terms of seeing what's raised by the various populations.
Right. There's a question that came through earlier, Rachel, I want to direct to you. And it's about how, excuse me, patient comment, the narratives can actually be expanded into patient stories. So going beyond a comment and turning it into something that allows you to see the whole patient. Any thoughts on that question?
Yeah, I think this is quite similar to what I was just thinking about with respect to the use of AI to analyze comments, that in the experimental and research work that we on the CAHPS team have been doing, we will most often do like a subset of longer interviews with people to get their full story. And sometimes that's to validate the narrative item set, and sometimes it's to learn about the impact of feeding narratives back into clinic. It can be lots of reasons, but I think the basic insight that we have generated is that this is not just useful for research, it's just really useful for understanding. And you don't need to be like a highly qualified qualitative researcher at all. It's really about getting out and talking to people in a regular way. So my recommendation is for people within health system settings to have the shorter written narratives, which gives you thousands of respondents and really like an ability to see what's going on, but also to make sure that you're really sampling and talking to, as representative, a subgroup of people. Even if you do 15 of these kinds of conversations or interviews every couple of years, and then really take a look at what you're learning. It's a really key element, I think, of improvement and understanding.
Very good. Denise, there's a question related to the potential role of community health workers in eliciting patient feedback. I mean, we've talked about how questions can be added to the survey instrument itself, but given your work with some safety net organizations I know that you've done out in California, any thoughts about using that element of actual workers, community health workers, to be a source of collection of this kind of feedback?
Well, what I think I would say is that, I mean, we do want the collection of the information still to be, in a mechanism so that the patient themselves feels that they're not going to have any of their care jeopardized by the collection of data, right? I think a lot of that's why even the CAHPS data, be it that you're writing in your comment in a survey or you're doing it online, it does allow you that anonymity. So I think that's important in many regards, especially because when you're raising, you may or may not feel comfortable always raising the patient safety issue with your, healthcare staff. I do know that it's also true. It's important to make sure that the patient themselves feels comfortable and confident expressing those concerns and don't feel like they're going to have any retaliation in any way or any pushback in terms of being able to gain the care they need if they have to continue to go to that same organization or site. So I do feel it's very important for organizations to make sure they maintain those mechanisms of clearly allowing patients and families to report anything that they're experiencing, good, bad, or in the middle of their care. So that's very different than having it be that you tell your nurse, something, right, or your healthcare worker. In the setting in the federally qualified health centers that I've worked at, they do have some what they call patient advocates that help, and they're more closely working with people with chronic diseases. And I think that all staff in many ways hear stories and do collect information about what they're knowing is on the ground. I feel like that's obviously important for staff to be able to speak up about things that they hear from patients as well. I don't know if that needs to be systematically collected, if that's what anyone is asking, but I think it is important because there are surveys for clinicians themselves to also be able to report things anonymously or, with their name on it as well for the same reasons that you think of for patients. So I'm not sure if it's going to be one of the more regular ways that I would see that people collect information from patients and families.
I think that's a great response. I think it also, the question indicates just, I think, a thread that's run through the conversation from the beginning, which is that there are multiple ways of hearing the voice of the patient through patient narratives written, through patient narratives volunteered on site, during an encounter, through other multiple voices. And I know that we actually had a webcast back in May where we talked about this very issue. And so maybe sort of the overarching kind of takeaway here is that there are ways in which all of these different potential sources of information coming from patients and families and their caregivers can actually be integrated into a more comprehensive way of looking at patient experience and complementing the closed-ended surveys. We're almost out of time, and I do want to give both Rachel and Yuna sort of one shot at sort of, if you had a kind of a takeaway message in terms of a lesson or sort of advice to others working in the field and collecting and trying to understand patient narratives, what would that be? Rachel, let's start with you, and then Yuna.
I'd just say that a lot of what happens in healthcare is about people and humans, and listening to what people say in their own words is a big part of being humans who use language. And I think it brings people back to the reasons that they want to be part of healthcare to begin with. So lean into that.
Great.
I would certainly underscore that. I mean, you are the organization's the heart and soul of the patient experience. And I think, we often think about this North Star of moving towards patient-driven improvement. And the way to get there is really through partnership with the organization. And so I think this work collectively is sort of progressing us in that direction. Yeah, thanks.
And Denise, the final word, just not to exclude you from the wrap up. Any nugget to pass on in 10 seconds?
Yeah, I would just say that I think it's just important to use the narratives in the context of the full survey, knowing full well that what you're getting is your performance over your larger set of patients, but making sure then that you use all the information that they're providing you, where the detail that they've willingly written out in also the assessment of what is needed to push care to a different level and to improve. I think it's important to use it hand in hand.
Okay, wrapping it up then. Rachel, Yuna, Denise, and John, thank you so much for your remarks. Let's move to the sort of the closing slides. We want everybody to know that you can sign up for updates from the CAHPS program by signing up for GovDelivery email updates. And the way to do that is to go onto the AHRQ website and select email updates, and then you can fill out what you want to receive, specifically the CAHPS news and events. Next slide, please. So a number of questions came through. We're never able to address everyone, either during the webcast or the registration, but you can always be in touch with us through multiple ways. By email at the email box chps1@westat.com. The 1-800 phone number, 1-800-492-9261, and the CAHPS website, which is full of information, citations, information on the research that's underway, databases, educational sessions on reporting and improvement, and just a wealth of information at www.ahrq.gov/CHPS. And with that, we're going to sign off. I want to wish everyone, thank you for joining us, and again to our speakers, our panelists, and hope that everyone has safe, wonderful holidays. Be safe, and we'll see you in the new year.